Hello class, today we'll be working in chapter 5. We'll be going over the integumentary system. So, the integumentary system consists of a series of accessory organs like skin, hair, nails, sweat glands, the oil glands that secrete onto the skin surface. As you probably know, this is actually the largest organ system by mass. So we're going to be going through aspects of the integumentary system today. So when you look at the skin, there were actually two layers and then a third supporting layer beneath that. And so the two layers of the skin are the epidermis and the dermis, and then beneath that you'll have the hypodermis, which is mostly just fat, but it's also helping to support the upper lying areas. So the very superficial region, the region that is exposed to the environment, is the epidermis, which is largely epithelial tissue. And if you think back to tissues, epithelial being one of the major four types, it is avascular. And so you need the supporting tissues of the dermis, that connective tissue, to actually supply these upper lying regions. And then beneath that, of course, is the superficial fascia. This is working in shock absorption and insulation and essentially anchoring the skin to those sort of deeper structures like the muscles themselves, right? That's that fascia. So here's a pretty typical cross-section of the skin. You can see the superficial layer of the epithelial tissue. Then just below that will be the connective tissue and the blood supply, and then just below that is the hypodermis, the adipose tissue underlying it. And so we see cross-sections of hairs, some eccrine sweat glands, some pili. So it's a lot of stuff going on with the skin itself. So let's look at some cell types that you're going to find out in the epidermis. So when we think of the epidermis, we should be thinking of this sort of stratified squamous shape. Remember that epithelial tissue is categorized based on the number of layers and the shape it takes. Well, when you get into these high stress areas, you're going to need lots of layers, and you're going to have these really flat stackable cells. And so this is mostly stratified squamous epithelium, but there are some other cell types that are helping to support us here. So the first is the keratinocyte, and its job is to produce the keratin. We call this a horn-like protein, rhino horns, toenails, stuff like that, made out of keratin. It's a major cell type of the epidermis, and it's bound very tightly together by these special junctions called desmosomes that when you look at them histologically, they look like rivets. And so we are sloughing off millions of these every single day. Then you have the melanocytes. So these have a very particular spider shape. They are quite dark. That's because they produce a pigment called melanin, which is actually helping to absorb some of the UV radiation that we're exposed to every day. And this is part of the pigment that is actually giving us our skin color, although we will see that there's other factors at play for that. You also have these dendritic cells. Anytime you hear the word dendrite or dendritic, you should think tree-shaped or star-shaped, lots of processes coming off. And in this case, they're patrolling these sort of looser areas of the epidermis, and their job is to present antigen to other immune cells. You also have some tactile cells here, so embedded innervations that are helping to sense and give us our ability to sense touch. So looking at the distinct layers of the epidermis, you'll have 4 or 5 depending on whether you're in the thin skin or the thick skin. So thick skin is going to have an extra layer because it's just a very high abrasion, so you're losing a lot of skin, especially from the hands and feet. And then the thin skin will contain the 4 strata. Presumably these are areas where you're not seeing those kinds of mechanical forces. But the 5 layers are, starting from the bottom, the stratum basale, stratum spinosum, stratum granulosum, the stratum lucidum, which is only found at that thick skin, and then the outer layer, the stratum corneum. So let's go through these. Starting off at the bottom, we have a basal layer, the stratum basale. It's the deepest one, and it's attached to the very top of the dermis. It's just a row of stem cells, essentially. So this is where mitosis is happening. This is where we're getting copies of these epithelial cells actually being made. And so one daughter cell is going to journey to the surface. This process takes 25 to 45 days on average, and as that cell is actually migrating out towards the surface, it will die, and so it will be filled with all sorts of chemicals, as we'll see, that help it to resist mechanical forces and make it waterproof, stuff like that. So the other daughter cell is not going to migrate. It's actually going to stay in the stratum basale and serve as a stem cell. So sometimes you'll hear this referred to as the stratum germinativum because of that active mitosis going on. You also see a lot of melanocytes here, and that's important because you want absorption of this UV radiation before it has a chance to mutate the DNA, especially in a stem cell line. Next, you have the stratum spinosum, or the prickly layer. It's only going to be several layers thick, but what you see is this pre-keratin filaments kind of invaginating this layer, and they're going to be attached by the desmosome junctions, the rivets. Basically, this allows them to resist mechanical forces. And so the keratinocytes at this point are looking kind of spiky, and so we call them prickle cells. And then you'll still see more of these melanosomes, these bodies with the melanin pigment packed in here. And you'll also see those antigen-presenting dendritic cells. Next, you have the stratum granulosum, or the granular layer. So this is where you're going to start to see the actual epithelial cells start to change shape. They're going to become more squamous in nature. It's 4 to 6 cell layers thick, but it's thin when you look at it in cross-section just because the cell's shape are changing. So the nuclei and the organelles are beginning to disintegrate. Remember, if your only purpose is to serve as a structural support, then you don't need all of the activity associated with these organelles. And so at this point, we're going to begin to keratinize the cells. And so they're going to take up these keratohyalin granules that will eventually organize into the fibers. You also see the inclusions of lamellar granules at this point. This is a type of glycolipid that is helping to waterproof that outer layer. And the cells are still alive at this point, but not for long. At this point, we're too far from that dermis layer to actually continue on. So the stratum lucidum being clear, when you look at this, it's only found in the thick skin, and it's going to make this translucent band of clear, flat, dead keratinocytes. And so in the thick skin, this is superficial to the stratum granulosum, but in the thin skin, this is absent completely. Okay, moving on to the stratum corneum, the horny layer. This is the thickest layer of the epidermis, about 3/4 of the epidermal thickness, and that's because it is 20 to 30 rows of those flat squamous keratinized cells. And so even though the cells are dead, they are still serving a number of purposes, right? They're resisting mechanical forces, they're preventing major loss of water, they're helping protect us from penetration, and they're serving as an external barrier against biological, chemical, and physical threats. Now, we've mentioned before that these cells are actually changing as they migrate up through the layers. So how are they changing? Well, first they go through this apoptosis event, which triggers the cell death. The organelles and nuclei themselves are, of course, being disbanded. They're having those lamellar granules inserted. The keratohyalin is assembling into the keratin fibers, etc. So these dead cells eventually will slough off as dandruff and dander. And we're shedding millions of these every day, so 50,000 cells every minute. So here we have a differential stain of the epidermal cells and the layers of the epidermis. Look at that. Now we'll move deeper into the dermis itself. So the dermis is going to be connective tissue. And as we've seen before, connective tissue is in some cases richly vascularized. It's basically feeding that upper epidermis. And so some cell types here would include fibroblasts, macrophages, mast cells, and even leukocytes, white blood cells. Like connective tissue typically does, this is going to be a very fibrous tissue, and it's sort of binding all this together. And so there will be innervation here, there will be vasculature, There'll even be some lymphatic vessels, so we've got some immune action going on. But this is where you're going to see the hair follicles, oil glands, and sweat glands. And then this is composed of two layers as well, the papillary and reticular dermis. So here is a light micrograph slide of a dermis cross-section. And so you can see the two divisions, kind of drastically different staining. The papillary dermis, which is areolar connective tissue, and the reticular dermis, which is dense irregular connective tissue. So anytime you see that sort of irregular tissue, it's moving out in all sorts of directions, basically to resist force from any direction. Okay, we start off with the papillary layer. This is going to be areolar connective tissue, so it's loose. It has interlaced collagen fibers, elastic fibers, and blood vessels. And basically the looseness of this tissue allows for the phagocytic cells to patrol here for cellular debris and bacteria. Then you have the dermal papillae. These are finger-like projections. Anytime you see the word papillae, it's like a process or a projection going out. And these actually have the capillaries in them, that is sending out blood in gas exchange. This is where you'll find the nerve endings and touch receptors that form the corpuscles, basically allowing us to sense pressure from above, so for our sense of touch. In the thick skin, this is going to lie on the dermal ridges. And so these dermal ridges are actually visible even in the epidermal epidermis. These are essentially where our fingerprints come from. So collectively, these are friction ridges, basically giving us better grip. And so this also contributes a little bit to our sense of touch due to the presence of those corpuscles. So that's what this is showing here, the friction ridges and the openings to the sweat ducts, basically contributing to our unique fingerprints. So moving deeper into that reticular layer, this is 80% of the dermal thickness and is going to be composed of a denser connective tissue. So the job here is going to be to reduce stress recoil, to resist mechanical forces, and then bind water, essentially keeping this layer of the skin hydrated with these collagenous fibers. In this tissue, you'll also find the cutaneous plexus. This is a complicated network of vessels and capillaries between the reticular layer and that underlying adipose layer of the hypodermis. So the ECM at this point is going to start to contain these sort of lipid-based adipose cells. So here you can see the dermal ridges in the characteristic skin markings. So these are important to know for surgeons especially. So you have these flexure lines basically occurring at the dermal folds, especially near the joints. At this point, the dermis needs to go even deeper to secure, basically. In this case, the skin is not going to slide very easily at those joint places because of these deeper creases. So it's basically anchoring the skin at deep points. And so when you look at your hands, this is going to be like at the folds of the fingers, the soles, the toes, the hands, the wrist. So you also have these tension lines that are visible formed by many collagen fibers running in parallel to the skin surface. And so these are externally invisible, but we know from our studies on cadavers and looking at this stuff for medical purposes, because it's very important that when a surgeon starts to cut on you, that they are working parallel to these cleavage lines instead of working perpendicular and cutting across them, because we know that this helps in wound healing. So there you can see the flexure lines actually forming the lines of the palm. And so anytime you have like a rapid weight gain or weight loss, you could be left with a stretching of the skin that can leave these striae or stretch marks. And so short-term traumas, burns, UV exposure, etc. can cause blisters. These would be fluid-filled pockets, basically separating, forcing that epidermis and dermis apart. Okay, skin color. So we mentioned some of these pigments before, but melanin, of course, is a pigment made in the skin. It's actually synthesized by those melanocytes. It's packaged into melanosomes, and its job is to help absorb UV radiation. Now, UV radiation has a high wavelength, so it does have the ability to damage or mutate DNA, which could eventually lead to cancer. It's made from the amino acid tyrosine, in this case by an enzyme called tyrosinase. And the more sun that your ancestors got, the more need for a protective shield you had. Thus, we tend to associate areas along the equator with higher melanin content. And so if you move to the northern latitudes, you don't have that constant sun exposure. And as we're going to see in a little bit, there is a synthesis of a vitamin that actually requires some sunlight. And in that case, having this melanin pigment in high amounts would not be conducive. Anytime you see freckles or a really dark pigmented mole, that's just going to be a localized sort of accumulation. And so melanin comes in two forms, a yellow and then a sort of darker black. So the sun is a huge fusion reactor. It's constantly bombarding us with tons of radiation. We need to be able to deal with that somehow. In this case, excessive sun is going to damage the skin. Basically, the elastic fibers will begin to clump up on themselves, causing wrinkles, for instance. It can depress the immune system and lead to mutations in DNA. Those can eventually lead to cancer if they build up in the correct order. UV light is also very destructive for an important biomolecule called folate or folic acid. And so this is necessary for DNA synthesis, and it's one of the few supplements that universally can get prescribed, but also especially important for development of fetuses. So increased sensitivity to the sun can come from a number of sources. It can be genetic, it can be drugs, certain chemicals, especially plants. Plant chemicals are pretty good at this, but it can lead to rashes, basically reactions at the surface level with the sun. So as mentioned, melanin is a very strong pigment, but there are other things that are contributing to skin color. One of these is keratin. This is going to be a yellow or sort of orangish pigment, seen most often in the palms and the soles where it's the thicker, I guess, but it's because it accumulates also in that stratum corneum and the hypodermis. So keratin is actually an earlier product that gets converted to vitamin A, which is important for vision and epidermal health in general, but being a fat-soluble vitamin is actually one of the ones that we see overdoses on most often. Another contributing factor is actually the hemoglobin itself in your blood. So hemoglobin is a very sort of red pigment that gives this pinkish hue, especially to fair-skinned people, due to the lower levels of melanin. And so our skin, the skin of Caucasians is more transparent, remember, higher latitudes, so the color of the hemoglobin shows through, thus that sort of pink hue of fair-skinned. We use alterations in skin color to sort of look at maybe causes of stuff. So cyanosis, the blue skin that you would get with perhaps a drowned victim or low oxygenation. There's pallor, so if you're anemic, for instance, that hemoglobin color could be from low blood pressure or some type of sympathetic response. There's erythema, the redness associated with fever, swelling, inflammation, allergies. There's jaundice, of course, which would be indicative of liver disorders and trouble processing the bilirubin. Bruises, of course, this is just like localized bleeding underneath the skin, clotted blood. The color of the bruise will actually change as that blood clot is essentially dealt with. And so you could see a sort of necklace of bruises in the hyperpigmented areas in the axillae around the neck. And this can be indicative of insulin resistance and high blood glucose levels. Okay, so moving on to the hair. Hair itself is actually dead, the part that we see, and it's going to be composed of these dead keratinized cells. You shouldn't see much hair on the palms, soles, lips, nipples, and portions of our external genitalia, but it has a couple different jobs for us. So it can be used as a sensory tool. Of course, we feel stuff moving around on us by the movement of our hair. It can help to guard physical trauma. So one hypothesis on the evolution of beards in primates is that the beards actually help to cushion blows to the head. It can help to protect from heat loss. So you actually have a muscle attached to your hair called an erector pili, and those will raise or lower the hair to actually create a thin layer of air underneath and provide some insulation. And notably, some hair is quite dark, right? It is also shielding the skin from sunlight and absorbing some of that harmful radiation. So the hair themselves, also referred to as pili, are just flexible strands of dead keratinized cells. They are produced by the hair follicle, and it uses the same protein that skin uses to give itself structure, but in this case it is a softer variety of it. And so the hard keratin is going to be much tougher, much more resistant to mechanical force, and the cells are not going to flake off as much. So two regions when you look at hair, the shaft area and the root. So the shaft is actually the portion that you're going to see. It's visible above the scalp. And at this point, the keratinization is complete. The root is where the keratinization is actually taking place. So three parts of that shaft: the medulla, the cortex, and the cuticle. So the medulla is a central core, and it's basically full of air. It's got these large, empty, flat cells and lots of air within. The cortex is going to be these flattened cells that surround it, and then the cuticle is these sort of overlapping kind of dragon scale shields that are helping to prevent like any kind of water loss. So the hair pigments themselves that give you the color of hair are actually made by melanocytes down in the follicle. And so these different melanin colors, yellow, rust, brown, black, basically are responsible for all of the hair colors that we have. One sort of notable exemption to that is red hair. Red hair is relatively new. We think maybe around 10,000 years ago, could have started from even as few as like a single individual, and it is due to a rare sort of mutation leading to processing of the melanin into a different form, in this case pheomelanin. So why do we get gray or white or silver hair as we age? Well, it's simply the melanin production decreasing as these cells begin to age. And as a result of this, air bubbles are going to replace those melanins in the cell. So here we have a structure of the follicle itself. You have the cuticle, the medulla in the middle there, and the cortex. And then, of course, we see the follicle wall itself. And here is the photomicrograph of a cross-section of hair and hair follicles at 100 times magnification. So, moving on. When you look at the follicle itself, it's going to extend from the surface to the dermis. And this is where you're going to run into the bulb, the hair bulb. This is just an extension, a sort of expanded area at the deep end. And so you're going to have some sensory nerve endings here, basically wrapping around the bulb. And this is allowing us to basically feel any kind of manipulation of the hair. When you look at the wall of the follicle, it's going to be composed of a peripheral connective tissue. It's going to be derived from the dermis, so very similar to what we see surrounding it. But basically it's forming the fibrous sheath around the hair itself. And so this glassy membrane is just a thickened basal lamina, so sort of like an extracellular matrix. And then the epithelial root sheath is going to be derived from that sort of superior epidermis layer. So the hair matrix itself is going to be the part that is mitotically active, so it's continuously dividing and kind of pushing that process up. As it makes new cells, it will move the older ones upward. And then there's the erector pili, like I mentioned, basically a band of smooth muscle, so completely involuntary, attached to the follicle. And when you're cold, you'll get goosebumps, which in this case is the erector pili actually pulling the hair up to create an air gap. The hair papilla has that surrounding dermal tissue basically tons of capillaries that feed and supply the growing hair with the nutrients it needs. And so here we have a hair follicle cross section from the other side. In this case, they show us the hair root itself also has cuticle, cortex, and medulla, and then the matrix, which is the actively dividing part, and the hair papilla, basically giving it the nutrients it needs. So there are actually different types of hair. For instance, when you're a baby, and even adult females will have what's called vellus hair, a very fine, pale hair. The terminal hair is going to be what we associate with hair as we would think of it on adults. So the scalp, the eyebrows, really starts to take off around puberty. It will appear in the pubic regions, and then on males, of course, you begin to grow facial hair. So this is affected largely by genetics, but also your environment. So nutrients, the hormones, etc. are going to affect that growth. And it's going to grow about 2.25 millimeters per week, and you're going to shed upwards of 90 of these scalp hairs daily. So sometimes we have some clinical imbalances with hair growth that would be indicative of some sort of problem, and a lot of times it's usually hormonal. So in women, the ovaries and adrenal glands are actually making androgens, which are the male sex hormones. And sometimes these can make a lot, like for instance, if you have like an adrenal tumor or polycystic ovary syndrome, this can lead to hirsutism, which is essentially hair all over the place, excessive hairiness, and other signs of masculization. Again, just being exposed to those male hormones, but it's not like a long-term acute problem, it's just sort of superficial. So hair thinning and baldness. This is called alopecia clinically, and it does occur in both sexes, but of course in males it's kind of leading to this true or frank baldness or male pattern baldness. And basically what's happening is the follicles are being exposed to this dihydrotestosterone, and it's causing the hair to fall out. And that is genetically determined. You probably heard the rumor in high school that it was your mom's dad. If he has a full head of hair, you'll have a full head of hair, but trust me, that's not true. My granddad had black hair when he died at like 85, and I am balding like at 31. So, talking more about clinical imbalances, this telogen effluvium, this will be a sudden onset hair thinning, essentially caused by the follicles kind of entering their resting phase at the same time. And so this is what we would associate with hair loss due to stress. So hormonal changes, the sort of impactful events like surgery or trauma, or even as simple as a change in your diet. And so this will lead to thinning of the hair, but there are other conditions, for instance, antidepressants. Of course, chemo treatments will affect hair growth, hyperthyroidism, and if your diet is not protein efficient enough. Okay, so that was hair. Let's move on to the nails. The nails themselves are just kind of these extensions or modifications of the epidermis that are made from this harder keratin protein. And so what they're doing is acting as a counterbalance, essentially. They're acting as a place for to resist pressure when you put your hands on something. It's also a protective cover because we do have bone ends right at the edge of our fingertips, and you want those to be protected. So the nail itself will have a free edge, a nail plate, and a root. And then we have this nail bed, essentially the epidermis underneath the actual hard part. And the portion of the nail that is responsible for the growth of these cells is the matrix, the nail matrix. So nail folds, if you've ever had a hangnail before, this is that skin that sort of comes over the top of the border of the nail. The eponychium, this is the projection onto the surface of the nail body. We can call that the cuticle. And then the hyponychium is the area under that free edge of the plate And this is where you get like dirty fingernails. This is the portion of your fingernail that is sort of overlapping and allows for material to get accumulated beneath. So your nails appear pink because you can actually see that sort of pink color coming from the hemoglobin of the blood cells in the capillaries. The white portion, that sort of half moon, is the lunule, and this is the thickened nail matrix, and it's going to look white. But this is where the cells are actively dividing. Nails are actually indicative of general health, and so any kind of abnormal color or shape can be an indicator of disease. And so here we have the free edge, the lateral nail bed, that lunule, that half moon sort of matrix area, eponychium, which is the cuticle, the nail plate itself, etc. So as mentioned, nails are a good indicator of general overall health. Any kind of yellow tinge could be a problem with your pH due to respiratory problems, or could be indicative of a thyroid gland disorder. Thickened yellow nails can be due to fungal infections. Spoon nail, outward concavity might indicate an iron deficiency. And then horizontal lines across the nails could indicate some type of severe injury like diabetes, heart attack, or even be due to cancer. And so here's that spoon nail we saw. Okay, moving on to sweat glands. Sweat glands, also known as the sudoriferous glands. These are going to be found in essentially all parts of the skin surface except for the nipples and the external genitalia. And those are going to have a different kind of sweat gland. There are about 3 million per person, and so this is actually why most of our glandular activity is exocrine rather than endocrine, because sweat glands are sending their products out of a duct onto a body surface. So two main types depending on how they work: a merocrine delivery system or an apocrine delivery system. The apocrine delivery system, I think, is still a little bit suspect. I think there's some contention whether that's actually holocrine in nature, but an apocrine gland is basically erupting from the apex, whereas a holocrine gland is just sort of blowing up. So these sweat glands contain the myoepithelial cells, and the anytime you have myo in there, it's going to mean some type of like contractory cell, like a muscle cell perhaps, and upon stimulation these contract and basically force the sweat out of the ducts. So first, looking at the eccrine sweat glands, they are using a merocrine delivery system. This is the most common type. It's found on the palms, the soles of the feet, and the forehead. And it's using ducts, basically ducts, to deliver its sweat product. And so we can take advantage of this and the high heat capacity of water to help us thermoregulate. This process is controlled by the sympathetic nervous system, so mediated by the catecholamines, and their secretion is going to be sweat. The composition of sweat will, of course, vary depending on how hydrated you are, but 99% water. There's going to be salts here. There's going to be vitamin C, antibodies, so this is actually sort of immune related. And then there will also be small peptides that actually have the ability to kill microbes on contact. And then of course we also get rid of our metabolic waste through sweat as well. So here is a cross section of a eccrine gland. So what you're seeing is the secretory cells, which are epithelial in nature, the duct, and then that supporting dermal connective tissue. So what about the apocrine sweat glands? So these are going to be found at the axillary and anogenital regions, and they're going to really become active around puberty. And so the sweat that's found here is going to be a little milkier in texture, and that's just because it has these sort of lipid substances in there and proteins. So this is the smelly sweat that bacteria can actually metabolize and give us a body odor. These are larger than those eccrine sweat glands that are far more common, and the ducts empty into the hair follicles themselves. So we don't exactly know what the purpose of these is. It's obviously doing stuff that the other eccrine sweat glands are doing as well, but it's possible that this was maybe an earlier form of a scent gland. And so there are some modified apocrine glands, the ceruminous, basically secreting the cerumen, which is earwax. And so these are found in the ear canal, and they secrete that earwax, which basically keeps stuff from building up in your ear. And then mammary glands are also like this, and they secrete milk. Okay, so moving on to another type of secretory gland, the oil gland or sebaceous gland, also widely distributed except for the thick skin. And so it's coming from a hair follicle and secreting into a hair follicle. These will be inactive somewhat until puberty because they are stimulated by the upregulation of hormones, especially the male sex hormones, the androgens. And their secretion is going to be this sebum. Sebum is a oily sort of lipid-based secretion that has bactericidal or microbial killing properties. But it's used to soften the hair and the skin essentially. And this is a holocrine secretion. So again, this delivery is the cell type essentially blowing up once it is full of this sebum. So here is a sebaceous gland duct, basically delivering its secretion directly into that hair follicle. So here's a good summary of the three types of glands that we see here: eccrine, apocrine, and sebaceous. And basically you can tell that these are all exocrine glands because they are all emptying into ducts. So clinical instance of this sort of clogging would be acne. Acne is actually inflammation or infection related to one of these glands, especially the sebaceous glands, filling up. And this is often due to a Proponia bacteria. And so when you take something like a tetracycline or an antibiotic for acne, this is what you're going to be targeting, the Propionibacterium. So eventually this can lead to whiteheads, the blocked sebaceous glands. The secretion basically becomes oxidized, leading to what we would call blackheads. So if you, in infants, this seborrhea, or essentially an overactive sebaceous gland, remember these aren't supposed to be superactive until you're going through puberty, can lead to cradle cap. It's essentially these lesions on the skin that will turn yellow and flake off. So that's what that looks like, just caused by overactive sebaceous glands. Okay, so let's take a step back and talk about skin as a whole. So skin is a barrier, right? It's the barrier between you and the external environment. And so its job is going to be to protect you, but also other aspects of regulation. For instance, regulating your body temperature. This is also the site of innervation. So we're getting receptors that are signaling our nervous system that we are sensing something, in this case, touch or temperature. There are metabolic functions going on here. It's a large reservoir of our blood. Remember that it's going to be in the dermis layer, but the integumentary system is also just quite large, right? It's covering our entire body. And we're also excreting waste here in the form of sweat. So protection. How is skin actually protecting us? Well, it's forming a barrier, essentially, a barrier to microorganisms, resisting abrasions, extreme temperatures, and harmful chemicals. Three types of barriers here: chemical, physical, and biological. The chemical barrier is going to be caused by the skin secretions. So for instance, the first of these would be sweat, of course, which has those dermacidins and antibodies. Sebum and defensins, which also kill bacteria. The acid mantle, so the skin itself actually maintains a low pH, which is not good for certain bacteria. And it's actually good for other sort of normal flora, but this is basically retarding bacterial multiplication. And then of course there's the melanin itself, that pigment that is absorbing the UV radiation. Okay, physical barrier. We have the stratum corneum, of course that 20 to 30 cell layer thick keratinized cell, and that is also surrounded by the glycolipids secretions. The laminar, of course, is blocking the loss of water, and so this can be penetrated. For instance, lipid-soluble substances, plant resins, organic solvents, any kind of salts of heavy metals like lead or mercury. Some drugs can actually be absorbed across the skin, for instance, nitroglycerin. And there are drug agents, essentially chemicals that will help other chemicals cross your skin barrier. Okay, moving on to biological barriers. This is going to be the cell types that we find here sort of patrolling these layers. So the epidermis itself in the thinner layers is going to have phagocytes. You've got the dendritic cells, which are essentially finding these foreign invaders and presenting them to the leukocytes to get them upregulated and activated. And then in the looser areas of the dermis, you've got these macrophages essentially moving around like little amoebas and basically eating or trying to eat any kind of invader or cellular debris. Then you have this sort of UV shield, right? You've got lots of nonsense DNA that is not coding for anything, that is sort of statistically serving as a barrier to mutation, but also, of course, those melanosomes. So one of the problems with the chemical layer, of course, is that some chemicals can actually penetrate our skin very well. So organic solvents, heavy metals, what happens if those do penetrate the skin? Well, the organs can be damaged. It can cross the blood-brain barrier to the brain and start to damage there. That's a very common one for like mercury exposure. Absorption of lead, leading to anemia and neurological defects. So whenever you're handling these materials like organic solvents, heavy metals, etc., they should never be touched with the bare hands. So this is why we have PPE for these kinds of applications. Okay, moving on to body temperature. So normally you lose a little bit of water just doing your everyday business. You don't even have to be hot. You're going to be losing 500 mils a day in the form of insensible perspiration. This is sort of a base layer perspiration that is always occurring. And as your body temperature rises, the vessels in the dermis themselves will begin to increase that sweat gland activity to where you can lose up to 3 gallons of this noticeable sweat called sensible perspiration. And the purpose of this sensible perspiration is to actually go on the skin surface, evaporate, and as it evaporates, it will remove some of that kinetic energy from the system. So the exact opposite is also true when it's cold, right? The dermal blood vessels will constrict, and now your skin temperature will drop to slow the passive heat loss from your more important core areas. So cutaneous sensory, the skin is also the hosting point for different types of mechanoreceptors and corpuscles that are essentially working as part of the nervous system to interpret touch and temperature in some cases. These free nerve endings are also where we are sensing our painful stimuli. So the cross section. Metabolic functions. So the skin is actually the site of vitamin D synthesis, necessary actually for calcium absorption in the intestine. The keratinocytes, of course, are having this function of disarming some carcinogens that we encounter just out in the external environment. Keratinocytes can also upregulate certain hormones, for instance, converting cortisone into hydrocortisone, so a stress hormone. The skin is also the site of collagenase production, and essentially collagenase is digesting the old collagen, basically preventing wrinkles and preventing buildup of these sort of old broken down proteins. Up to 5% of the body's blood volume is being stored here in this reservoir of blood. And so this becomes useful when you need to shunt blood to other organs. For instance, the muscle. Muscle has a very high blood demand because it's using lots of oxygen to make lots of ATP. So the skin vessels surrounding the muscle can actually shunt blood to the muscle in order to help keep it fed. Excretion, of course, via those ducts that we saw, those various glands. Some secretions are being passed through the sweat. For example, ammonia, urea, uric acid. These are nitrogen waste products that are coming from just normal protein breakdown, but you need to get rid of these somehow. And so we do this by sweating. Okay, moving into damage to the skin. There are over 1,000 different types of conditions and ailments related to the skin. Many of the sort of deeper conditions can be diagnosed clinically by looking at symptoms that are affecting the skin. Most commonly, these are just going to be in the form of infections by microbes, but some less common but also bad are skin cancers and burns. So let's talk about skin cancers. This will actually be a discussion topic, I believe. So cancer needs two things to be true for a cell to be considered cancerous. One, it has the ability to metastasize, and two, it has unregulated growth. Now, a benign tumor, which is the most common kind, has growth, but it's not going to metastasize, so it's not going to spread. But risk factors for these kinds of tumors are exposure to UV radiation, which is damaging the DNA, mutating it, and eventually leading to some kind of uncontrolled growth. And then areas of frequent irritation of the skin. So we can actually supplement our skin products to have these sort of reparative enzymes and mechanisms. But essentially, there are three major types of skin cancer that we're going to go over. The basal cell carcinoma, so occurring in that basal layer, squamous cell carcinoma, and then melanomas. So basal cell carcinoma, very common. It's the most common and the least likely to actually metastasize and turn malignant. But what's happening here is those cells in the stratum basale are now undergoing uncontrolled mitosis and proliferating at such a rate that they will actually begin to pass deeper into the dermis and hypodermis. In 99% of cases, these can be fixed very easily with surgical excision. So like I said, very common, but moving on to the second most common type, the squamous cell carcinoma. And this can actually metastasize and become cancerous, moving to other organs. This is due to the keratinocytes of the stratum spinosum, leading to a reddened papule, especially common on these sort of vulnerable areas that are getting lots of sun, your ears, lower lips, and hands. But if treated early, good prognosis, can be treated with radiation therapy or surgically removed. So there's squamous cell. And then the melanoma, the most dangerous type of cancer, very highly metastatic, very resistant to chemotherapy. In this case, you're going to require a wide surgical incision and immunotherapy because you want to be sure and get rid of all of those infected cells. And so this is going to be strongly associated with moles, for instance. And so we have this ABCD rule for diagnosing these types of cancers. So when you look at a mole, you need to keep these things in mind. Is it asymmetrical? If the two sides of the pigmented area do not match, that means that it is invading these other tissues. Border irregularity, does it have a lot of indentions? Color, is it very dark, for instance, black, brown, tan, sometimes red or blue? And diameter, is it larger than the size of a pencil eraser? If these criteria are met, there's a good chance that this is a cancerous melanoma. So there's a melanoma. Okay, moving on to burns. Burns are damage caused to the tissue by heat, electricity, radiation, and even chemicals. There can be chemical burns as well. What's happening is this high energy is coming in and essentially destroying the macromolecules in this region. So it's denaturing proteins, destroying cells, and the immediate threat here is not only the release of the products from these lysed cells, but dehydration and electrolyte imbalance, which can flood the body and cause renal shutdown and circulatory shock. To evaluate burns, we use something called the rule of nines. There are essentially 11 sections of the body. each of which compose 9% of the body surface, and then the genitals account for 1%. And so when we look at burn victims, we can estimate the volume of their fluid loss by determining how much of the percentage of their body has actually been burnt. So we classify burns by severity. The first degree is just that epidermis layer being damaged. So you're going to see localized redness, swelling, and these are going to hurt, right? Because this is where those tactile sensors are. A second degree burn is going to extend deeper into the dermal regions. So you're going to see blisters appear. Remember, blisters are fluid-filled sacs that are essentially forcing the epidermis and dermis apart. And these two are the partial thickness burns. In this case, only the epidermis and upper dermis are involved. Now, increasing in severity, we have the third degree burn. Third degree burns are very severe. They are full thickness burns that are going through the entire thickness of the skin. The skin itself will turn color, and it's not really going to hurt as much as those earlier types of burns because you've actually destroyed the nerve endings in these burns themselves. And at this point, you're unlikely to be able to salvage this. You're going to have to skin graft. So, continuing on with burns, if greater than 25% of the body has second-degree burns, these are critical. These are life-threatening. If 10% of the body has third-degree burns, or if the face, hands, or feet get third-degree burns, right? These are areas of high mechanical force. If you destroy the tissue there, that's really bad. And so, treatment is going to include the removal or the debridement of that burned skin. You're going to need antibiotics in order to resist even just the native flora from taking advantage. Temporary coverings to keep just detritus and debris out of your burns, and then in extreme cases, skin grafts. So here's an illustration of the rule of nines. Essentially 11 body sections, 9% of the surface area each, the genitals accounting for 1%. And this is how you can establish how much fluid has approximately been lost by a burn. Okay, let's talk about some embryological aspects of the integumentary system. So by the end of the 4th month, a fetus will actually have skin. And so it has a lanugo coat. These are essentially a series of fine hairs that cover it. And the vernix caseosa is the sebaceous gland activity, basically secreting this stuff that's going to protect a fetus while it's in this watery amniotic fluid. So as we progress to adulthood, the skin itself will begin to thicken. You're going to see more subcutaneous fat. You're going to see the sweat glands and the sebaceous glands increase with hormone changes, eventually leading to acne. And optimally, during your 20s and 30s, this is when your skin is going to be the healthiest. But after about age 30, the cumulative effects of just the assaults of our environmental conditions and our own natural aging is eventually going to start to catch up with us. And so scaling and dermatitis are going to become more common, and a thinning of the skin will actually be seen. So aging skin. The epidermal replacement is going to slow down. That stratum basale is not going to be mitotically as active. The skin itself is going to become thinner, drier, and itchier because of decreased sebaceous gland activity. The elasticity of your dermis and hypodermis is going to decrease, and as a result of this, cold intolerance, wrinkles are going to increase, and older people are actually at higher risk of skin cancer due to decreases in melanocytes and dendritic cells. And as mentioned, both sexes will experience hair thinning beyond the age of 40. So some ways to actually protect yourself, of course, especially here in Texas, would be good UV protection, wearing sunblock, wearing hats, wearing long sleeve. I haven't been the best about that, and just like both my grandfathers were farmers, and both of them were absolutely riddled with skin cancer. But good nutrition, so making sure that your skin is being well taken care of, lots of fluids, and then good hygiene, just keeping that skin clean. So that was the end of the Integumentary System, Chapter 5. Thank you and have a good day.